Well, welcome. Today we're going to cover a topic that we hope none of our viewers will ever have to deal with. But as we've said, when you need specialized medical care, when things aren't perfect, it's so nice to know that we have world-class services and medical staff right here in the center of the universe in Milford. So, why don't we start with an introduction and tell us your specialty?
I'm Stephanie Macausland, and I'm a radiation oncologist, and I specialize in breast cancer.
I'm Jennifer Pretz, also a radiation oncologist, and I work with Stephanie and also see breast cancer patients.
So now you're so close to bringing a new life into the world. How do you deal with radiation?
The radiation these days is very focused. It's safe for the patient, it's safe for the technicians who deliver it, and it's safe for the physicians who are working in the facility. So there's lots of good protections in place to be able to continue to work in this state.
I was going to say, because I mean, nothing you want to put at risk more than a new little baby girl.
That's right, that's right.
And I'll get comments, I know, saying, well, what happened to the boys? Well, as a father of two girls, I don't even think of the girls. So Stephanie, tell us about the state of medical care today. I mean, the minute you hear the word cancer, everybody panics.
Yep. We have a wonderful program here at Milford, so I can't speak for the whole country because I know it's very different in different parts of the country, but what is great at Milford, we have a comprehensive cancer center, and we work closely with the surgeons, with the there's a navigator, there's pathology, radiology, medical oncology, chemotherapy, and we work together to, right when you hear the cancer word, you're going to already have a meeting set up to meet with all of the group of the whole team, so you get a big overview of what you can expect, where you may go, what are the options. I think it really allays your fears. I have a good friend in New Jersey who had breast cancer, and when I told her our process, and she's actually a physician, she could not believe, how different it was where she was and how she wishes that she had that service. So I think we do a good job of trying to allay people's fears when they hear that word.
But now when you start down the road and you hear the word cancer, I mean, your blood pressure, last year they found a spot on my lungs, and you know what that means is right away I'm thinking, that's it. It's going to be the long bus ride, hopefully north. If they give me suntan lotion, I'm not going to be happy on that bus. But, it's hard to think straight. Mm-hmm. You can't necessarily do something, it's not like smoking to eliminate lung cancer. I mean, what can a woman do, or a man, to minimize what they'd have to go through? Is it just self-checking?
There's self-exams are certainly encouraged, and many women, find the cancer themselves by feeling a lump in the breast. But there are good screening programs now, and the recommendations are for women to undergo annual mammography screening. And the whole point of screening is to, if there is going to be a cancer there, to catch it early.
Get it early.
Catch it early, and be able to, receive treatment, early and appropriately for the stage of cancer as it presents.
But you still recommend self-examinations.
Self-examinations and examinations by a care provider. Many primary care providers perform annual clinical exams, which are also a good component of kind of breast cancer screening.
And there's no age on this, right? As early as you start, the better.
I think there are different guidelines that suggest different ages for starting. Some say as early as 40.
Right.
Which is a reasonable time frame to start thinking about it for a woman with no other kind of familial risk factors or anything of that sort.
And when I saw the argument on funding you know, the mammograms. It stunned me. You know, I mean, they quoted all these great statistics and how you don't really need them starting at 40. Am I missing something? Because, you know, I sat there and looked and said, if it was my mother, my wife, my daughter, I don't want to hear the stats.
Yeah.
Well, I mean, there are different guidelines, but we still in radiation oncology advocate for yearly mammograms starting at 40, and you get into monetary and political issues, and there are different statistics, but we still advocate for annual mammograms, and insurance is still covering that.
Are they still covering
I
annual?
believe so. Yeah.
Yeah.
I mean, I just can't imagine, you know, when you think of, yes, it costs money, okay, but you're putting, you know, your spouse, your child, you know, your mother at risk.
Right.
It just doesn't make any sense to me. You know, the self-examination
Right.
makes perfect sense. Making sure that one of the check marks when you go for your annual physical is a breast exam by a trained physician. Okay, what's the downside? Except for the obvious, you know, poking and prodding that,
Sure.
you know, I mean,
Right.
you got to get over the fact that, I mean, even going into that miserable machine can't be very pleasant on anybody's schedule.
No. But
But is there any real downside?
there's minimal, very minimal. The benefit we feel outweighs any type of risk involved. And catching an early breast cancer is a whole lot better than late breast cancer. There's so many different options and obviously different prognosis. So,
And it's, I mean, obviously we focus all of our attention on women's breast cancer. But with men, I mean, the sensitivity is not there. I remember when I went in once and they found a lump. And of course they asked me, have you been subject to any trauma? I can't remember any trauma. Later on, they enlightened me to say, playing hockey and getting hit with a 90-mile-an-hour frozen puck
Counts as trauma.
counts as trauma. I never thought it was trauma, it's just hockey. But I remember they just went in and whoop, out it comes. Luckily, both sides, you know, over a number of years, were benign. But it was never a worry. I didn't get counseling, and it was just kind of like, yes, you have a lump, we're taking it out. I mean, I hate to be sexist, but I would think to most of the men, having a scar or losing part of a breast is not a big issue.
for some men it is, believe it or not.
Really?
So, I've had a couple men that and wanted to preserve the breast, so it happens.
You know, I find it amazing because when you talk about the risk of cancer, you know, as we were talking before the show, if cancer's behind door number 1 and death follows with it, I don't really care what's behind door number 2. You know, yes, I would like to be a young, thin man with hair. I look in the mirror, there's a fat, rotund, old, bald man looking back at me. I got to deal with it. But, I mean, it's got to be a much harder issue for a woman to deal with.
Yeah, body image goes along with the treatment of breast cancer, especially for women. And, you know, the modern therapies that we have now, kind of modern surgeries, modern radiation techniques, other medications, make it so that patients have options in the treatment of their breast cancer. And they have different kind of functional and cosmetic outcomes associated with them. So it is more of a conversation about, you know, how we can still effectively treat the breast cancer, in many cases preserving the breast and preserving a lot of the cosmetic outcome. But even still, it is kind of an emotional process to go through for many patients.
Well, I mean, and again, being an old man who's been fortunate that my darling bride has tolerated me for 100 years of marriage, this whole body image thing, losing her or having a different body, how could that take more than 2 seconds to process through my old mind to say, it's my best friend? You know, we talk about you come from 2 girls and the mother of my children, the one who's built our family and maintained it. Why would I ever care? And I mean, I'll never get that through to her. You know, because you try and explain that in my eyes, she's still the most beautiful, intelligent woman I could ever find. Why she married down to me, I don't know, but she's paying the penance for whatever she did. But the whole body image thing, you know, it's hard, especially for an old husband to understand. But I guess we just have to be sensitive and try. How do I say this politically correct? What should an old man do while his wife is going through this? Because you want to be supportive, but you know, when you talk to some of the people whose wives have gone through it, they don't know how to react. What do you tell, I mean, because you got to deal with the whole family, what do you tell them?
I think it's important for, like you said, it's mostly the women who worry about what the man thinks, and that's almost always the case. So, you know, you talk to the couple and you try and have the woman understand that the man doesn't like say what you said to them in a room, so that they hear it, and try to promote a conversation even when we're in the room, so that, you know, the wife can hear it, or the significant other hears that conversation. But it's difficult because I think women, though, are also so involved in their own self-image, and most of the men really don't have your view of it.
We went through this on a minor level through pregnancy. She looked the most beautiful I've ever seen her, my darling bride, when she was pregnant. Try and tell her that.
No.
You know, or even my daughter.
Right.
All I heard was, I'm bloated, I'm big. It's like, no. You're having my daughter. She's gorgeous.
Right.
You know?
Right.
But you feel bad because, you know, I've listened to some of the kids and the husbands who said, we try and be supportive, but we don't want to go too far.
Yeah.
And say, it really doesn't matter. As long as you're healthy, what comes out, who cares? But you can't say that, because that ain't going to work. You know, so do they put the families, this navigator, does he or she bring through like counseling services for the families?
Absolutely. That's definitely a major role in the breast center and the navigators, to bring counseling, bring families together, and they assess it originally on that diagnosis and try to figure out the needs of the family and the patient themselves. So it's just a host of resources we have to help the patient and the family.
And that's been one of the great things of having the alliance with Dana-Farber. You know, is that you don't have to go all the way to Boston. You don't have to pull somebody away from, I mean, when my mother had her intestinal cancer, there was a calming effect that she was in her little, well, I can't call it little hospital anymore. Ed will get mad at me. Yeah, it's not the little red Milford hospital that we grew up with. But she was in her town.
Right.
She was at home.
She was at home. There was a psychological benefit to her to being home. And we drove in 10 minutes, not an hour and a half of traffic getting her all wound up. So there's got to be a huge benefit to keeping it all in Milford. But now, okay, so we've done our self-exams. We've gone to the physicians, and unfortunately there's a lump. Where does it start? I mean, there's choices, is there not, for dealing with breast cancer? There's chemo. How do you determine, do they go to you? Do they go to a surgeon with a knife? Or do they take a pill or an IV? How do you select?
Many times, all of those are used in the treatment of one patient's breast cancer, but it depends on how advanced the cancer is when it's caught, what the treatment options are. That's why it's so valuable for the patient to meet the medical oncologist who might deliver the chemotherapy, the surgeon who would be doing the surgery, and the radiation oncologist who would be doing the radiation up front when they get their diagnosis, before any treatment path has been decided upon. So that, together with their oncology team, they can be educated on the treatment options for their particular type of breast cancer, and know the team that'll be taking them through those steps. Often it does start with surgery, and then there's a discussion of whether or not chemotherapy should come after that, and then after that would be the radiation, but not.
But the treatments have gotten much less severe over the decades. When you think about the old days, I mean, they removed an entire breast.
Right.
Mm-hmm.
It was almost like you see the Civil War with the saws and, okay, you got a
Right.
problem, you take off the leg.
Yeah.
And you sit there and say, oh my God.
Yeah.
It's come a long way.
It's very
and
different.
Yeah, it's very different. And most of the patients are able to preserve the breast, and that's most of patients' desire. There's some women who, I think because of media and some, celebrities and actresses that get the breasts removed, so there's some that sort of are nervous about preserving the breast.
The Angela Jolie
Right,
factor.
yes, yeah, exactly. But most women will opt for breast preservation, and the large majority are good candidates for breast preserving
Well,
therapy.
when you look at people who have a genetic indicator,
Right,
okay, so we do some sequencing, we find a certain gene and say, the odds are not good.
right.
Can you look, I mean, is it a density issue in the breast? Is there anything that you can look at? Because when you say it got advanced, well, if I'm checking every month and I'm having a physician check every year, how does it get to an advanced stage without me knowing?
Well, I mean, inherently, not all breast cancers are the same. And so there is different biology driving different breast cancers. So when you are screening appropriately and doing your yearly checks, odds are you will catch it at an early stage. However, there are some just biologically different cancers that
Are
when
there
they start.
asymptomatic breasts? You know,
Most of the breast
Most of
cancers
them.
are you don't feel anything.
so it is kind of, you're going to feel a lump.
Most of them you don't feel a lump, and you don't feel any pain. But if you feel pain, it doesn't mean it's not cancer. Some people think, oh, it's pain, so it's not cancer. I've had several handful of patients that said I had pain in the breast. I always taught that pain doesn't equate to cancer. It doesn't mean, it's unlikely, but there's always that chance it could be, not to scare anybody out there, but you always should seek medical attention for any changes that you experience. But it's usually asymptomatic. You can't feel it. You don't.
See, as a layman, you always hear breast cancer starts with a lump. Yeah, but you're saying no, it could be asymptomatic, and you could be checking, and your physician checks, and
Right.
how does it manifest then? How do you find out?
Often those types of cancers are found on the mammograms.
Oh, really? Mm-hmm. So telling people they don't need one once they turn 40 makes no sense at all to me then. You can give me the statistics, but again, if it's somebody that I know,
Right.
Sure.
you don't want to deal with statistics.
No.
So what are you looking for on the mammogram when you actually, see the breast? Is it dense areas of tissue? What do you find that would say we may have a problem?
Yeah, there are different features that the technicians and the radiologists look for that distinguish something from being normal breast tissue. So there is a certain kind of uniformity in most women to the breast tissue, and when they take the mammograms, and there's some focus or area that looks more dense, more heterogeneous. You compare to prior mammograms to see if that spot, has been that way for, many, many times over, or if it's something new or different compared to the last mammogram. Those are the types of things they look for to say, this needs further evaluation.
So if I've looked back over the years and there's a continuity, a homogeneity to the tissue in the breast, and all of a sudden, wait a minute, something doesn't look right. The highway doesn't all run straight now. There's some curves in there.
Yeah.
That's when you start paying attention.
Yeah.
Yeah, and there's newer technologies in mammograms. So Milford Hospital has a very new technology called tomotherapy imaging, and it actually images more in a three-dimensional plane than just two images, and it's able to distinguish between just normal breast tissue and an abnormality a little better than our traditional two-plane
So the
mammogram.
tomography gives you better depth?
It gives you, but it puts it more in 3 dimensions, so it can tell that sometimes there's just dense tissue or overlying of different tissues. It's able to distinguish those things and detect it a little better. So, and Milford has that newest technology. It's helpful.
Well, that'll be especially nice for old men, because I remember when I went in, the technician looked at me and it's like, oh my God, there's nothing there to smush, even though I'm fat. She tried everything to try and get.
Yeah, it's not easy.
Yeah, and at the end, the results were the same. We're cutting it out. You're a guy, who cares? But now, I do the best I can. I find out it is cancer. I've got options. What would be why would I go to chemo first or surgery first? I know you can't, there's no, how do I say, the perfect reference breast. You can't go and say, here's the perfect reference model. So if you vary this way, we go that way. I mean, they're all going to be different.
Right.
But where do you start? What are the decisions that drive you towards surgery, towards radiation? Because, I mean, radiation scares people. You go in, you're like, okay, medium well, please, not well done. Where does the physician start? What kind of guidelines drive different treatments?
Well, I mean, every case is very different, and there's so many nuances to it. But where you start, it's usually surgery first. But sometimes, if the breast cancer's very large and it's requiring removal of the whole breast, because you would just have a little tiny bit of breast tissue left after removing it all, then oftentimes there'll be discussion about chemotherapy to try and shrink it down so that you can preserve the breast. It's also, if you have a locally advanced cancer, it's something you can, if you get a good result, it makes, the patient feel good, and you can see that, the chemotherapy is actually working. So psychologically, that's, sometimes a good thing. So that's one reason you would do chemotherapy prior to surgery. But in general, most women will go for surgery first, and then analyze the tissue as to their special test called an oncotype, and it sends your tissue out to a lab, and they run all of these fancy tests to see what benefit you would have with chemotherapy based on the actual tissue from the cancer, and that's fairly new.
No, I hadn't heard of that.
And then the radiation component, it's often how we choose who to give radiation to. It factors into what type of surgery they had. So Stephanie mentioned breast conserving therapy earlier, as opposed to way back when every woman got a mastectomy. When you conserve the breast and do a smaller localized surgery and just cut out the area where the tumor is, we almost always follow that with radiation so that the whole breast does receive treatment, although the whole breast doesn't have to receive surgery.
But now when I think of chemotherapy, maybe my own jaundiced view, but I think of, okay, I'm trying to do a balance of killing the cancer a little bit faster than killing the patient. And I think of all the stem cells that you're nuking, it just seems like chemotherapy. unless it's a systemic issue, wouldn't be my first choice. I mean,
It's nobody's first
i-
choice.
if you can go in, I mean, the old days, surgery was massive. Radiation felt like, okay, you're putting me in a nuclear reactor and I'm zorching you. You know, what I read today is the shape of the treatment. I mean, you've come so far with radiation, you know, that the doses seem, I won't say nominal, but compared to what, you know, we grew up with 20 years ago, they're much lower. So wouldn't I rather have you come in and just take, you know, and we're talking about breast, but it could be any part of the body.
Right.
If you can take a rifle shot versus, you know, I look at chemo and it feels like it's a nuke.
Right.
Right? When somebody says, what's the benefit of radiation, what would you tell them?
Well, radiation and chemotherapy are quite different beasts, and what they're doing is quite different. The chemotherapy is something, it's all insurance usually. I tell patients, after the lump is removed, for most patients, chemotherapy and or radiation are really insurance policies, and it's a matter of how much insurance you want to take out. But with the chemotherapy, it's an insurance to try and clear out any little cell that may have escaped and floating around in the body, in the bloodstream.
When you're saying insurance, not insurance reimbursement.
No, not insurance.
Because I was going to
No,
say, somebody's
no,
saying, wait a minute,
no.
I'm sorry, you don't
Right.
have a really good insurance policy, so you know,
Sorry.
the anesthetic is a hammer to the back of your head. You know, we got to save money here.
Right.
No, but
No,
you're
I
just
meant
saying,
insurance so that it won't come back and you will never have a problem with it again. So chemotherapy is killing any little cell that may be floating around in the blood that we can't detect. And it travels throughout your body and it cleans up any cell that may be, you know, around that we can't see. So it's very different, and radiation is a very localized treatment in just treating usually the breast, sometimes some of the lymph nodes as well, but it's a local to that area, and it kills any little cell that may be left behind. No fault of the surgeon, just that sometimes cells are a little skip around the breast or can hide in a lymph node. So that's cleaning out any of those cells locally.
so if I have a circulating tumor cell, the radiation isn't going to necessarily get to it, correct?
If it's outside the breast, correct, because the radiation is very focused just to the breast
You're
area.
doing a very minimal amount of radiation, because that's better for the patient, but you're going in right at a point. So if a few of these guys are sneaking around in the circulatory system or being drained out in a lymph node,
Right. It's not going to, radiation does not get to those. That's what the chemotherapy will do.
and the chemo goes through the whole body, any fast replicating cells, unfortunately like stem cells, are going to get caught up. It's like a big net. So why would I use, I'm trying to, you know, as people go through and bringing it down into, you know, a baseline,
Yeah.
you sit there and say, okay, if it's a small surgery and that fixed everything,
Right.
ooh, that sounds good.
Right.
Not good, but
Right.
less bad. So I go in, I do a little lumpectomy,
Right.
but I can't count on the fact that I've gotten every single cancerous cell.
You know, it depends on the features of it and what it looks like when it's removed. But and like I said, for the usually they'll send out a little piece to see, you know, what the risk is that this, even though it looks like you got it all, there may be a little cell in the bloodstream, and that test would show, you know, what risk that is for the chemotherapy. So when the surgeon, it's sometimes difficult. It's a hard concept that the lump is removed and the surgeon, meaning very, very well, says, you're cancer-free, I got all the cancer, and then we come in and say, oh, we recommend radiation, and they look at, the patient looks at us like, what? We said, my surgeon said I'm cancer-free and I got all the cancer, and the surgeon's right, but the patient, you know, it's
Well, the surgeon
difficult, to have
is not going to
sometimes
try and cut out a large area. They're going to minimize the
Right.
envelope
Sure.
just for the deformity, just not even appearance-wise, but, the less you carve out of my body, the better it is.
And they go by, visually what they see and what they can feel. Microscopic cells can't be seen by the human eye, can't be felt by the surgeon's
Even the best
fingers.
surgeon is not going to be able to see a few loose cells here and there.
Yeah.
Right, exactly. And like you said, a breast surgeon's also judicious in what they're taking out. I tell patients that we're probably one of the only cancer doctors who care about cosmetics because, if you're doing other surgeries in the belly or other parts of the body,
That's
it's
hidden.
not right. In breast cancer, all the breast cancer physicians are very cognizant of cosmetics because if a surgeon's just going to remove a huge chunk of the breast and leave a real small, breast that doesn't look very good, then there's really no sense of preserving the breast. So surgeons they want to remove, everything and give a nice clean area of tissue also remove, but at the same point, they don't want to remove so much it's not going to look right at the end. So it's a balancing act
because
for
if they
them.
take too much out, then the reconstruction is going to be that much more intense.
Right.
Yeah.
And,
Right.
there's the psychological effects.
Exactly. So it's a balance, and it's like I say, one of the only oncologic areas that's very always a
Sure,
discussion.
not too many people worry about what their liver looks like.
Right.
Right.
Exactly.
You
right.
you sit there and say,
yeah,
well,
right.
don't take too much of my liver. Well, that would
Right.
regenerate. Don't take too much of my kidney, because I don't want to lose the appearance. I'm sorry, when I sew you up, see you later, bye.
Right. So it's always part of this discussion. Obviously, number one importance is to cure a patient and to have them never have to deal with cancer again. But in the conversation from all of the multidisciplinary specialties, cosmesis does come up and is an issue.
Now, after I've gone through the surgery, and they've done the biopsy. Obviously, you're taking the physical tissue, and the pathologist does their magic. Do they do liquid biopsies to see if there's any circulating tumor cells? I mean, how do they check it out that there weren't a few little stragglers here and there?
There's not really a blood test they can do to assess whether or not there are microscopic cells in the bloodstream. The tests that we do run to help us inform that is what Stephanie mentioned, sending a little piece of the
Sure.
actual tissue itself that was taken out of the breast to a lab to run some tests on it to give us a feeling of the biology of the tumor and give us an indication of whether or not that tumor has some features that might make it more likely to have done that, in which case chemotherapy would be a part of the discussion. But unfortunately, there is no good blood test for
We keep
breast cancer.
seeing all the
Yeah.
new diagnostic tests that
Right.
all these companies are coming out.
Yep.
Yeah.
And in theory, like NIPT, it's wonderful that you don't have to go through amnio. That you can look for a trisomy and see if the odds are high for Down syndrome.
Right.
Yeah.
So I remember when they asked my darling bride if she wanted the amnio, and there was almost an equal probability of spontaneous miscarriage
Yeah.
to
risks.
Downs.
Yeah.
Right.
And I remember walking out of the room saying, anything, just don't. You say the prayer that says, do what you want to me, but don't do this to my daughter. And I know it's silly, but I remember the angst, just, as a father, you feel so helpless. So when you start thinking about the same thing with cancer
Right.
cells,
Yeah.
I can see looking at the tissue around the tumor they
Right.
cut out
Yeah.
and saying, okay, is it all nice and healthy?
Right.
Because, you're going to want, I guess, I don't know enough about it, but an envelope of healthy tissue.
Exactly.
Yeah, and the pathologists do specifically look for that and comment on that on their
Yeah,
reports.
if you see tumor cells in the envelope, it's like,
Right.
Yeah.
Exactly.
you didn't take enough.
Right. Right. Definitely.
But, I just get concerned because I see all the research, some of the stuff coming out of leading institutions, the Mayo and all the others, Mass General, about liquid biopsies, going in and taking blood.
Mm-hmm.
And they've done incredible diagnostic feats
Right.
to keep you from having to harpoon a mother. Call it any way you want
Right.
it, but sticking a large needle in my darling bride got me very nervous.
Mm-hmm.
But like you say, trying to find 1 or 2 cancer cells. Even now with the genetic assays that we're doing for single cell, you can't take all the blood out of you.
Right. Right.
So you do have to go back then, just to be safe,
Mm-hmm.
to chemo.
Right. If it's, if like not everybody gets chemotherapy when they have breast cancer, so you're weighing the risk and benefits of everything. So you're weighing the risk of the chemo versus the benefits, and it depends on how big your cancer is, what it looks like under the microscope, what the little signals it has on it, and then even more sophisticated analysis of the cancer to give you. They're never, no, it's nothing they say you need chemo or you don't need chemo. It's generally, it's up to the patient, and, it's a risk benefit, and if the benefit of getting chemo, if there's it outweighs what you consider a risk, but for everybody that's a different mark.
Again,
some people think 1%.
there's no reference human.
Right, exactly. So somebody can think is maybe a 1% benefit for you. Maybe you're going to survive 98%, and chemo will give you 99% chance of surviving. There's some people that will say, I'm going to take that, and others will be like, no way. So
Is that right?
yeah, everybody has their own
Different threshold. Yeah.
threshold of what they accept.
Yeah, you can't say they're right.
Nobody's
They're both
right.
right.
They're both
Yeah, for
exactly.
themselves.
You know, at the end of the day, I don't know what I could say. If it was my darling bride, it's really her decision.
Exactly.
And all I can do is support it,
Yeah.
not knowing how, but try, the best you can to support whatever decision,
Yeah.
whether to chemo or not to chemo.
Exactly. It's very individualized. So that's why when patients come and say, what would you do if it was your mother or your daughter? And it sounds like a good question, but it's not, because
Because it isn't.
Because it's not. And that's why we don't treat our mom or our daughter, because I'd want every 1% for them, but that doesn't make it right, or that doesn't, it may not be appropriate for my mom, who probably would do nothing, and that's her personality and what she wants. So it's so individual, and every patient has to, in some way, assess that for themselves.
So now, after the surgery, we think we got everything. Life is back to normal, as normal as it can be after you've dealt with this. Now what happens? How do I assess the patient? You're telling me that a lot of the women are asymptomatic, so it's not like I can go find, did I leave a bit of a lump? Did I leave a pebble that I can feel? So what happens from when the surgeon and the oncologist and everybody says, we think you're clear? Now what?
Once you're complete with whatever kind of oncologic treatment was recommended for you, whether that's chemotherapy and or radiation. But once that's all done, our patients go into kind of our surveillance protocol, which basically means that they are coming in more frequently than they would have otherwise for clinical exams, and they are reset up for their mammograms. And it's, again, those two things in combination with, what the patient is telling you, if they're having any new symptoms or feelings in the breast, that allow us to follow them long-term out.
So you do more mammograms and look for, again, that homogeneity, that continuity.
Yeah.
And a physical exam. It becomes a little more difficult to do physical exams after you have surgery and radiation. The breast tends to be lumpier. It tends to
Or scarred.
be scarred, right? So patients can get very anxious. They've had a diagnosis of breast cancer, and now they're feeling a big lump in their breast.
Well,
which
yeah,
is
I
a
could
scar.
imagine you go and you do a self-exam, and all of a
Right,
sudden you say,
so-
there's a hard area.
Right,
Yeah.
right.
And it's
right.
not a little pebble anymore, it's a
Yeah.
You know, it's a much bigger heart area.
So patients have to learn their new baseline and learn to follow it themselves over time, and with their physicians too. That's why they're seen more frequently by their oncologists who can follow that with them.
Yeah, I mean, that's one of the things that, you know, firsthand with my mom. To her, 10 years later, it's still Mona. Mona takes care of me, you know, and Dr. Cadis.
Right,
It was never Dr.
exactly, yeah,
Cadis, it
right.
was Mona. You know, my mother's 92. And for, you know, umpteen year, well, so many years after
Right.
her cancer surgery, there was something comforting that you're going back to
Definitely.
the same, you know, oncologist or whatever, you know, the same
Right.
person that's riding herd over your treatment. You're not having to try and explain to a not that a new person's any better or worse, but I noticed that the physician not being different had a very important calming effect on my mom.
Absolutely. I mean, we, the radiation oncologists follow as well as the medical oncologist, and the amount of time depends on the patient's comfort and who else they're following. But I had actually 2 patients today that I was ready to release because I felt they were being followed by a lot of different doctors, and you know, you don't want to feel like, you know, to put the burden for the patient to come, but they both, you know, were a little shocked when I said that they can follow with the others, and they, you know, still felt the comfort of coming. So I, you know, always give that option, and because it is psychological too. To if you have you develop great bonds with people and patients, and
Well,
and I think
let's
that's
see,
really
Stephanie, you
important.
just saved my life, or you saved the most important person in my
Exactly,
family.
right.
How can I not develop a bond?
Right. So we're fortunate that we have really, we developed this really close relationships with patients, and we follow them. And like I said, it's time frames vary according to the patient's needs.
Now, in previous shows with other physicians, we've talked about how the radiation is now shaped and it's so much more targeted, so you're not doing a shotgun blast. But after it's done, for the women who had a chunk taken out, okay, that there's an issue. It's not going to look the same.
Right.
It's not going to hang the same. It's whatever. There seems to be a lot of really good work for reconstructive surgery in the last 5-10 years.
Yeah, I think, you know, along with all the other specialties, you know, plastic surgery has also evolved with their techniques. And there are plastic surgeons who work specifically with breast cancer patients, and, you know, whose expertise is in reconstructing a breast and you know, optimizing the cosmetic outcome to be as good as it can be. So yeah, there are, you know, physicians out there now who make that their, you know, main goal and their main specialty.
But when you look today, you know, way back when, there was a large percentage of the tissue that would be removed. So the reconstruction, I don't know how they did it, but became a major
Right.
issue. Today, I mean, I don't know how to put this analytically, but what percentage of people lose a large amount of tissue?
I mean, like I said, I think it's all discussed up front, and that's the prospective meetings we have to discuss, you know, whether, because if you're going to lose so much of your breast tissue, and it's just not, the
It may not be
recommendation would
worth saving the little bit
right, and
that's-
you may do the chemotherapy first, or you may, you know, we may, you know, opt for mastectomy, because sometimes the options in mastectomy reconstruction are almost easier in some ways than, you know, just left with a little piece of breast tissue, and then you have to have radiation. So it's really a group decision way before you start, have your surgery. So it's really important, I emphasize to the audience, and you get the diagnosis of a breast cancer, really encourage whoever, to see a team prior to just having a surgery. And you can, get the best surgery for you, and you won't end up with a situation where you had the surgery, you had radiation, and now you have something that looks just really awful.
Now, just the two of you, this is probably an obvious answer, but to a layman, if you're removing a large amount of tissue, you envision there's now a hole. How do they reconstruct? What's involved in creating, the same shape, feel, whatever?
So, after a lumpectomy, where the surgeon thinks it's appropriate to just take out the area where the tumor was and leave the rest of the normal, healthy breast tissue, the breast actually on its own can do a really amazing job of kind of filling the tissue
So
deficit
they'll
that was
regenerate
taken.
the area?
It's not regeneration exactly, but the tissue that's there settles into a contour, and there's some fluid, that the body accumulates as well, that can really fill in the space. And the surgeon with the patient kind of makes that determination up front. If the surgeon thinks that they're going to have to take so much tissue in order to get the tumor out, that the tissue deficit will be large and kind of disfiguring, they then at that point might say, let's not try and save this other part of the breast. Let's do the mastectomy and take all of the breast tissue, but then realize that there are reconstructive options that may be, kind of more pleasant as far as an outcome
When you
is
say
concerned.
reconstructive, you think of building back, but if you've removed,
So reconstruction in breast cancer can take a couple different forms. One is actually implant reconstruction, where there are breast implants put in to mimic looking like a breast tissue. There's also reconstruction using tissue from another part of the patient's body, using abdominal tissue that's moved up to the breast.
So you're doing like a skin graft.
And muscle and tissue graft underneath that as well, so that that tissue can be formed and molded to look and take on the shape of a breast, even though it's not actually breast tissue.
But it would solve, if you're worried about body image,
Yes.
it would solve that issue.
Yes.
I mean, whether it feels or whatever the same, that's, okay, you're alive. You're alive. It would deal with anything else.
Right,
Yeah.
right. And everybody has their own threshold. We talk about risk and benefits. Everybody has their own threshold for that. Everybody has their own threshold for what they think is acceptable for breast, image, and after all the treatment. I tell women, I have 30-year-olds to, they have half the size of their breast, and they're totally fine with it. And you have 80-year-old women who have just a tiny deficit and really bothers them. So, it's not age, it's really just personal, and insurance does cover for any reconstruction process after the diagnosis. So, that's a discussion and follow-up, and whether people want to go and see somebody. And it's not a matter of what I think it looks like, it's a matter of how they perceive it and
again,
what they want.
It's much harder for somebody like me, an old man, because all I'd see is my darling bride's alive. Whether the breast was the same as when she was 30, yeah, excuse me, she's alive. My
Right.
best friend, I can talk to her, right?
Right.
The mother of my children is still here for my grandson. The appearance of a breast, and again,
Right, and it's-
purely from the father's point, I can't imagine I would care. If I do, shame on me. Somebody ought to take a 2x4 to my head and say, wake up. But from a self-image,
Right.
yeah, again, you can just be supportive.
Exactly, and like I said, insurance covers any reconstructive process that is available for that, and it doesn't matter your age. Self-image is still important. So,
Well, like you
right,
say,
exactly.
a 30-year-old, while they're going through the mating ritual and all that, or it's probably the self-image is more important to them. You get to an 80-year-old, okay, if it's important, great, but I cannot
No,
imagine.
I know, but
It
I've
can
had,
be.
right, it can
It
be.
can-
It
it
can
can
be
be,
very
yeah.
important.
Well, no, if
so
it's important to
not-
them,
Yeah.
great.
Exactly.
But, you know, at this point in my life, I don't think I'm going out. I mean, old, rotund, and bald. I don't think there's anything for self-image left. I am what I am. But now, you know, we talk about a breast. Is it common or more common that you have issues with both? Or is it mainly, or the majority of the times, a single breast issue?
The majority, it's a single breast issue. There are a small percentage of women who do have a genetic disposition for forming breast cancers. It's a very small portion of the population, but in those women, they are more likely to form more than one breast cancer. And so there are, you know, there's genetic counselors and genetic testing that you can do to kind of assess that. But by and large, the majority of the population who develops a breast cancer, it's going to be, you know, just the one.
And I mean, that's always, it seems like the debate. You know, okay, we're going to look for the BRCA gene, we're going to look for the...
Right, right.
It doesn't mean you will get breast cancer. Doesn't mean you won't. That's got to be a really tough position for a physician to be in. Because what do you say to somebody you're genetically disposed to? Now it becomes, I guess, your tolerance for risk.
Exactly.
Yeah.
Exactly.
You know, and I don't understand. I mean, the Angelina Jolie effect.
Right, right.
Got all the press. Isn't this wonderful? And I said,
Yeah.
the problem I had with it is, for her, it seemed like great. She felt better. It was her decision. But you can't extrapolate that to every woman.
Right.
And that was the issue I had with this. The media just seemed to say, this is the greatest thing somebody could do.
Right.
I guess I didn't understand, because it might not be for everybody.
No, exactly.
You know, and any medical treatment that you try and make universal scares me.
Right.
You know, until we get the reference genome for the reference human, you know, and everybody's exactly the same. You know, if we had a bunch of clones, then you could come up with a reference.
You'd need a reference cancer too.
And
You know, as we've already talked about, every tumor is different, and you know, everybody's predisposition to forming cancer is a little bit different. So, yeah, not all treatment options are going to
So
be the
now,
same.
when you do your treatments, question always comes out. Okay, you've done, with the tools you have in your hand, you've done everything you can. Still not winning the battle. Do you look for clinical trials, or what's left?
In general, are you talking in
Just
cancer
in general,
if things...
somebody
yeah,
comes in,
Yeah.
you know, you've cut, you've
Yeah,
nuked,
Yeah.
you know, you've chemoed, and you're not winning.
Yeah, so I think clinical trials are an excellent avenue. The Dana-Farber has the cutting-edge studies, encourage patients who really still have the fight left in them we have some trials, a lot of trials open in our Milford office, and some...
Oh, really? You're
some
doing
we
clinical
do.
trials here?
And some do go into Boston. And then, but there's also some patients that we have a wonderful palliative care services as well. And I think you're going to be speaking to some of our partners, colleagues in the next couple weeks about palliative care.
Right.
And that's a separate issue, but that's also, it's hard for a physician to broach those, you know, that idea that maybe this is, we're not going to extend your life, but we, you know, talk about
make
making
what's
you
left
comfortable.
more pleasant.
Right, exactly. And it's probably one of the hardest things that physicians have to sometimes tell patients, but one of the most important as well. But I won't, you know, steal
but I
their
think
thunder.
The biggest concern is that, okay, I believe y'all and people like Mona Kadis and them will, bar none, do everything the best they can with the tools they have. But the question is, okay, if the tools you have aren't enough, am I limiting myself versus going in, you know, to Binney Street or, you
Right,
know, to the Jimmy Fund building and
right,
finding out what new tools?
right.
But you're saying no, because you have access to the same information. So whether I'm sitting in Boston at Dana-Farber,
Right.
or I'm sitting in the Milford Dana-Farber, my options still stay the same.
Oh, absolutely. Yeah, those resources are all available.
I
Definitely.
mean, that's, especially in clinical trials, because at least in the techniques and technology you're using,
Right.
okay, it's been vetted, you know its limitations, but in clinical trials, we really, as much as we pretend that, you know, the animal trials and,
Right.
you know, the phase 1 for tox, and we've done all that.
Right.
I mean, the reason we're doing clinical trials is we really don't know.
That's right.
Exactly. So it's definitely a big subject, and not for everybody, but definitely helpful. Even if it didn't work for you, it's helpful for the whole population, and it's very available at the Dana-Farber and Milford. So definitely a good options.
Amazing. When we think of the Little Red Milford Hospital, what it's grown into,
Yeah.
you know, and I think one of the biggest things we've talked about is the environment. Because when you have people physicians who've stayed here for many, many years, it just, psychologically, the benefit is hard to measure, but you know it's there.
Exactly. Well, it's a wonderful community, and we all, I think, feel extremely lucky to be here and practicing medicine here. I don't think not all of us have grown up in Milford, but we've grown to love it in truth, and it's a wonderful community, and we're all blessed
Some
to
of
be
us have
here.
grown up closer to you. My home was right at the edge of the parking lot that was actually
Wow.
owned by Milford Hospital. You know, so it's been an amazing journey, and with Ed taking the helm,
Yeah.
I'm sure that it'll continue what Frank and Ed built.
Absolutely.
So,
It's been-
as always, it's hard because the oncologists are an incredibly skilled, caring group of people that I hope you never meet. But feel comfortable that should the day come when any one of your family needs that kind of care, you've got unbelievable people with the best technology and the knowledge to reach out to specialists in Boston, around the world, that if the tools they have today haven't progressed to a point of helping, the new tools will be available to you. So thank you for everything you do. And as always, may God bless to our 6 loyal viewers. May tomorrow be a better night than tonight. Thank you all. Thank you.
Thank you so much
Thank
for
you.
having us.